You're welcome to my channel. Today I'll be talking about Lennox-Gastaut syndrome. By definition, Lennox-Gastaut syndrome is a rare progressive epilepsy syndrome characterized by complex, severe childhood onset epilepsy with multiple and concurrent seizure times, usually from 3 to 5 years up till adulthood. It has a genetic component with several gene mutations but poorly understood, mostly by an existing Neuro pathology. When it comes to the epidemiology, LGS is in about 3 to 4% of all children with epilepsy. The onset is at 3 to 5, not common to have onset after 10. It affects males more than females, but it doesn't follow any particular race, so no racial predilection. It can occur without neuro problem, but mostly secondary to neuro problem. In Finland, the incidence is about 2 per 100,000 live births within 10 years. At age 2, West syndrome could be the first to occur and be the first case, and later on progress to LGS. It starts from childhood, but more frequently found in adolescent and adulthood. The seizures that will be found in LGS will include atypical absence, myoclonic, generalized tonic-clonic, infantile spasm, tonic, atonic, or status epilepticus. The clinical features will vary and progress with age. There will be triad, and the triad will include seizures, cognitive dysfunction, and when you have your EEG, there will be changes. So the triad of seizures, cognitive dysfunction, and EEG changes will be present. The above triad may not be obvious until 1 to 2 years after the first seizures attack. Also, signs and symptoms will be that there will be repeated daily seizures, repeated and daily. And you will try all anti-epileptic drugs and none will be working. The infantile spasm, otherwise known as West syndrome, will be the first symptom and then progress to LGS, that is the Lennox-Gastaut syndrome. Then you can have tonic seizures that will present with stiffness, and this will be more during non-REM sleep. There will be subtle presentation in form of eyelid opening, changes in breathing, pupillary dilation, urinary incontinence, tachycardia, and flushing. Also, there may be status epilepticus in about 50% of AGFs. That might be non-convulsive and atypical absent seizures. Still on clinical features, the atonic or drop attacks will be characterized by sudden fall. Note this, the drop attacks here will be the first signs that LGS is here. Remember, from infantile spasm, that is West syndrome, then progressing to LGS. Now, with LGS, drop attacks will be the first sign. Intellectual disability is going to occur. The intellectual disability will be present because there will be intellectual developmental delay. It may actually occur before the diagnosis of LGS is made, so it can actually predate diagnosis of LGS. Then we'll be dealing with generalized myoclonic jerk or twitches before the toning contraction of the axial muscles, that is, muscles of the eyelids, the head, the trunk, the back, abdomen, and the chest. The ocular anomalies with LGS will include refractive error, strabismus, cortical visual impairment, and premature retinopathy. Behavioral problems will be present, and in this case, we might be dealing with hyperactivity alone or ADH. There may be agitation, aggression, and autism. Still on clinical features, the epileptic encephalopathy here will be characterized by low spike waves on EEG, as low as less than 3 Hz on awake EEG. What are the possible causes? Metabolic disorders, though not very common, but we should rule that out with our blood and urine test. Other causes will include idiopathic, when we don't know the cause, or secondary. Secondary is about 75% of all AGS, while idiopathic will be found in about 24%. The secondary has worse prognosis than idiopathic. 1/3 has no identifiable cause or causes. Still on causes, mostly due to brain injury or brain damage. Might be secondary to encephalitis, meningitis, stroke, intracranial hemorrhage, central nervous system tumors, congenital brain malformation. Now, genetic component. Mutations in CHD2, GABRB3, ALG13, SN2A could occur. Some that have been previously adjudged to be idiopathic may actually have genetic disorders. Also, in tuberous sclerosis or inherited methylene tetrahydrofolate reductase deficiency. Differential diagnosis. If it's not truly LGS, what could it be? Could be atypical benign partial epilepsy, also known as pseudo-LGS, pseudo-Lennox Gastaut syndrome. But that will have different spike and wave pattern on EEG. Might be Dravet syndrome, but that will have long family history of epilepsy, and that could be triggered by light and temperature. Might be DU syndrome, that is characterized by myoclonic seizures. How can we make the diagnosis? It may take years before making the final diagnosis. So the history will include multiple seizures and different types of seizures. And of course, we have to trace the child, whether it's present or not. Some features are present while others may not be present, but we have to continue to follow up the child. We must do full and thorough physical examination. Anti-epileptic drugs will not be working, and that will give us a clue that we are dealing with LGS. So we'll have our EEG done, electroencephalogram. Let's have the awake EEG and the sleep EEG. We can have our magnetic resonance imaging done, and we'll head to lab. Electrolytes assay, renal function test, liver function test, the value of the glucose, acid-base balance, complete blood count, and depending on the degree of suspicion, you can have toxicological screening. Now, the treatment. There is no cure, but we can decrease the frequency of the seizures attacks using diet, surgery, medications, and then we have to support the family members or caregivers of the kids or children or the individuals already diagnosed with AGLs. So family support. Now, the medications that we may choose from will be valproate, That's the first to try. If we are not winning, we try lamotrigine. Rufinamide or topiramate could follow. And last resort here would be phlebamide. Again, there's no cure, but you can try certain medications. The first to try will be valproate. If we're not winning, lamotrigine. Then, if we're not winning, rufinamide, topiramate could be tried as third choice, while phlebamide could be tried as the last resort as per medications. Then we can have adjuvant. That is additional medications on top of the primary medications to be used. In that case, we can go for benzodiazepine, and we will choose clonazepam or nitrazepam or clobazam. We can also go for zonisamide or cannabidiol. Still on treatment, when we are talking about surgery, the surgery may be with or without implanted devices. The surgery will permit or give room for brain development during the seizure-free period. It might be vagus nerve stimulation or corpus colostomy if vagus stimulation fails. And then you can proceed to transcranial direct current stimulation, and you may have resection. When it comes to diet, ketogenic diet that is rigidly followed is expected to reduce seizures frequency. Finally, the prognosis. 6% will actually die over 10 years. And they will die mostly from seizures-related injuries. Please kindly check my channel for all other presentations already published on seizures disorder, including treatment and all these necessary precautions that should be taken to keep the affected people alive. With that, I've come to the end of this presentation as per AGS, that is Lennox-Gastaut syndrome. Thanks for listening. Remember to share this. Remember to subscribe to my channel. I appreciate it.